Hello and welcome to the May edition of the Leadership Ground Rounds. And we are super excited about our uh, conversation this May. We have a great guest. Well, actually, we have two guests that will be speaking to us today. And they come all the way from California. I have Emily Lamarana. She is the Director of Respiratory, Pulmonary, and Asthma Program at the Children's Hospital of Orange County. She has experience in leadership, education, quality improvement, and research. She received a bachelor's degree in biology from UCLA and her master's in respiratory from Rush University. Emily serves on the board of directors of the American Association of Respiratory Care as the chair of the neonatal pediatrics section. She is actively engaged in several national organizations as a consultant and a leader for respiratory care. Emily has received national recognition as a AARC recognized practitioner and was named the 2020 AARC Neonatal Pediatric Specialty Practitioner of the Year. She was also recognized as by the Orange County Business Journal, recently named Emily as their OC 50 of 2023. 50 people shaping the future of the healthcare in Orange County. I also have Corey Silito. He's the respiratory therapist with 33 years in our field. He also serves the sleep services, clinical education, and healthcare leadership. Corey has led key quality, safety, and compliance initiatives, working closely with interdisciplinary teams to implement and sustain best practices across respiratory care services. He has also contributed to numerous strategic initiatives such as iCare Study, which is a research, a low tidal volume ventilation, and a SAT and SBT enterprise implementation project supported by an NIH grant. Please join me in welcoming our speakers for today.
Thank you so much, Bali. Corey and I are really excited to speak with you all today. So today we're going to do kind of a two-part series of a case series of how to effectively both implement the SESG. And we're going to start from the very beginning. If you come into your institution and you need to influence your institution to make the change to use the only evidence-based RVU or unit of service to capture respiratory care productivity, give you some best tips on how to make that pitch. And then once you have effectively done that, Corey's going to share a story in his example of how to actually leverage a system-wide approach to the harmonization and implementation of productivity measures across an entire system. So we are excited and happy to start this discussion today. So I want to start with, okay, how do we even start this? You walk into your institution and you know that your budget is not correct and your productivity measure therapists are doing. So I'm going to share a little bit of a case study, and this is a personal story from me here at my institution. So about 2.5 years ago, and what you are seeing here was what I walked into. So we had 94, I'll say 95 FTEs filled, but we were only budgeted for 84.6. So immediately, my boss, who I report to the CNO and VP, said, I do not understand the respiratory care budget. I know they're busy. They look really short-staffed, but they're so in the red. Can you just tell us what we're doing? Because I can't make sense of it. But we don't have any positions open because you're technically overstaffed. So, for day one, I had to get right to work and understand what was actually happening. So yes, on paper, we looked about 10 FTEs over. We had no open positions. We weren't opening for travelers. But when I did the work to actually figure out our functional FTE, and I did a quick survey of what the work for the current patients who were in the building, we actually needed 115 FTEs. So by doing this work, I demonstrated and I said, I know exactly what's going wrong. You actually need, we're about a 33% vacancy, and we're actually short about 28 RTs. Again, that was a quick synopsis, but thankfully, having told them that they trusted me and they said, okay, get some agency in here while we actually learn and figure out what's going on with the budget and why it's not correct. And this was our productivity report. And if anyone has any questions, this much red on your productivity report is not a good thing. And this is very hard to get, it is very hard to ask for positions when your productivity report is showing that you're only 75% productive, or you're between 18 and 30 FTEs over every shift. So I understand why they just did not have a leader in here to actually be able to tell that story and explain what was happening. So our team was chronically short-staffed. We didn't have positions opening, and there was no plans to. So I got right to work. And my number one tip is get as many advocates early and often. I walked around with this PowerPoint slide with a flash drive, and anyone who gave me 5 minutes of their time, I took the time to educate them. That included my medical director, my CNO, who then saw my presentation and said, you need to talk to my boss, who was the COO. Every time I had any conversation with the finance team, who felt so bad for me, they said, we don't know what's going on. It's so red. And I said, this is what it is. I gave my story enough times. They got me in front of their boss, and then eventually in front of the VP of finance. So I would say you cannot do this alone. And most everyone else in the hospital is not going to understand respiratory care in the way that you do. So the first thing I did was I taught them what RTs do. They think about treatments, they think about vents, but they don't understand the wide breadth of procedures that we are actually dependent on. And I said, at the end of the day, yes, we do a lot of things, but that's not actually the value of an RT. If we're doing what we do well, we are assessing and treating. We are going to implement new measures. We're going to escalate care when necessary. More importantly, what you want my RTs to do is we're going to de-escalate care that's no longer needed. And that is going to save you money, because we're not going to have wasted resources. We're going to improve length of stay, length of time, and we're going to have a cost savings on that end. So I really had to drive that in with people for no other reason other than, they depend on the RT leader to teach them this, had no idea what RTs do. So then I had to teach them a little bit about productivity, because at that moment, our productivity measure or unit of service was adjusted patient days. I think some percentage outpatient, some percentage inpatient, and I had to share with them why that made absolutely no sense for respiratory care. And we went through it. You can use patient days and case mix adjusted discharges, but this is really a poor indicator of workload intensity for respiratory care services. Can reflect total mix, but doesn't reflect acuity. Charges and CPT codes. As we know, more than 50, I'll say even probably more than 75% of RT procedures that we do that brings value are not captured in CPT codes. You have your ventilator assessments, your SBTs, your rapid responses, high-risk deliveries, transports, any procedures at the bedside. And honestly, as we know, most RT charges do not generate revenue. We are not a revenue generating service. However, our services save money in patient care outcomes and improved length of stay and improved care. So I had to tell them, I had to explain, they can't just look at the number of charges that we drop. The average daily census, there could be a mass casualty event with, 100 kids with broken arms that would probably not need any RTs. Or I could have 10 patients come in who are on an oscillator and need to be prone or in severe pediatric ARDS, and I would need 4 RTs. So you can't just take sheer number of patients. And I had to go through this with them because they could not understand it. And I said the only validated metric and evidence-based metric to measure productivity time is our validated procedural times. And when I'm looking at my productivity, I want to see the time spent performing these very specific RT procedures. And then if I'm doing it correctly, the time spent for labor. So that makes sense, right? So if my RTs, a 12-hour RT does 12 hours of work, they should be 100% productive. But then we often think of 100% being the goal for productivity. But I want to make us question that and see if that's even feasible or if that's really the number that we should be looking for. And then I introduced them to this, the Safe and Effective Staffing Guide, which many of them had not seen. And I said, hey, it's been around for more than 30 years. This is actually the only gold standard in identifying those standard procedures I was just telling you about. The primary goal is ensuring the adequate number of RTs to meet our very specific patient demand. And it has been around for so long, and it has validated measurements of the time standards that are reported by hundreds of hospitals in every category across the country. If it's not statistically significant, it's not even reported. That is how valid this book and this resource is for RT leaders, and it really is our gold standard. If you want to read about it, there's a bunch of case studies that will show you how different institutions either improve their budget, improve their safe and effective staffing for their departments, had cost savings associated when they implemented the SESG methodology. And if you don't believe that, there's issue papers, position statements, peer-reviewed manuscripts, federal and state regulations. And this is all important because when you have your quick 15-minute elevator speech, they want to know, okay, you're charming, you seem really intelligent, you seem to know what you're talking about. What does that matter? And when you show it's federally, it is nationally recognized, there are peer-reviewed manuscripts and there's evidence, that's what's going to get the attention and make the difference when you're pitching to whether it's your finance team or your C-suite or senior leadership. And you can mention all the things that you have no idea what to do because RT budgets and everywhere does not make sense. If we do this, I can accurately help you project what we need next year. That new unit we're building with 12 additional beds in our CBICU, I could accurately predict how many RTs we'll need for that. How patients come and go, they'll get discharged, they'll get extubated, they may get intubated. The needs between shifts are going to also change. I'm going to be able to adjust my staffing to meet the very specific need at that moment. And you'll no longer be confused of walking around the hospital and seeing RTs running around busy, but being confused because your productivity report is all in the red. It will actually accurately reflect our productivity. So the first question they asked, okay, this is a great story you're telling. Is anyone else doing this? And I said, absolutely. And this is the second tip I always say is use your network, use all of us. I can tell you through the AARC and through many of my national organizations, the greatest asset to me is my network of leaders who are really there to just help and give all the resources to see everyone else succeed. So this is just a few. This number has grown immensely since then. But at the time when I was making this, I used Seattle Children's. I used a large hospital system in the tri-state area in the Midwest. And I used a children's hospital on the East Coast. And I said, yes, all of these hospitals and those leaders were kind enough to share their stories and share them so that I could use them as a benchmark. Because what I want to share with you is this is a big task. You are going into an institution. You are telling them what you have been doing for the last 20, 30, 40, 50 years is not accurate. And I need you to change the system for all your 500 cost centers just for me. And when you feel the barrier, it's not that they don't care about respiratory care. It's not that they don't want to help you. It is just that is a huge ask. You are asking them to change their entire financial methodology and what they believe for just one cost center. And they want to make sure, is this the right thing to do? Is it evidence-based? And the question I always ask is, what is the benchmark? What are other top 10 children's hospitals doing? So this is the second most important thing you need to do before you even jump into your argument. And then you have to say, and this is how we're going to apply it here, because then they're going to say, they ask, so what? You have this book, other hospitals are doing it. What does that mean here for us at CHOC? So first, what I like to do is I like to have them shadow an RT for about 4 hours, run around with the RTs, see what those procedures are, watch them wait 10 minutes for an elevator, see how long it takes when they get an emergency call and their entire plan for the day is disrupted. I need them to see all of those things that happen throughout the shift of an RT for them to really understand. And I explained here at CHOC, every RT goes out with 600 minutes of work. And of course, that begs the question, oh, they're getting paid for 12 hours when they're only doing 10 hours? And I say, great question. Well, our total shift is 720 minutes, but the RTs, they give start of shift report, they give end of shift report, and I'm here in California where they have mandated 15-minute breaks 3 times a shift. So really, what you're telling me is that the RTs have 15 minutes of free time throughout their shift. And, at this point, they had shadowed the ERTs, they had taken an elevator for 10 minutes, they watched how your entire day can get side railed by one emergency. And I said, now, does that seem feasible? Do you understand now why we target 600 minutes? And I kind of said, so if they're completely busy for that 600 minutes, what that's going to look like on your report is that they're 83% productive. But you now understand that what that means is they're actually running around the entire shift with maybe 15 minutes to take a breather, have an emergency, go on a transport. And I do also next share the data that the national average clinical productivity is actually around 82 to 85%. So I start this new campaign, 85 is a new 100, but it begs the question, when we're looking at our productivity reports, what actually are we targeting? I also remind them, unfortunately, we're not genies. I don't finish with my one patient and magically appear at the bedside of my next patient, don and doff in all of my gear with every medication and piece of equipment. And so I really try to paint this picture of what the RT's workloads are like. And I say, if we use this methodology, we'll be able to accurately calculate all the procedures that patients are on. Every unit is going to update those procedural lists, submit them to the house lead. The count will be entered and we'll be flexing and we'll be able to calculate how many RTs are needed for that shift and project for the next shift. Here's some examples of what we do. So here at CHOC, every RVU is 10 minutes. So you can see when we target 600, we're really trying to get them as close to 60 points per RT. Because the next question is that 4 patients, 8 patients? And I always say, it depends. It depends on your very specific patient and what's going on with them, and it'll vary. But if we utilize this, we can actually ensure that every RT is going out with a fair workload. And they submit this as a very busy slide. I apologize, but this is an example of what the numbers that are submitted throughout the shift that project the number of RTs needed per unit and overall. And I do want to mention that here at CHOC, we are lucky enough to have 4 non-allocated RTs. And these are RTs that when possible can go out without an assignment. So our house lead, our L&D, our transport, and our resource. So that's a hard thing to ask for, because when you're talking about productivity, I'm essentially saying I have 4 RTs with no patient assignments. However, if you go back to the 15% of non-productive time, saying if an RT is busy for their entire shift, there's gonna be about 15% of that time that they're not of all of those emergencies that occur. These 4 essentially make that up. And then I capture their productivity and ensure that they're staying busy, and I have to prove that, but it has worked out every single time that they understand that these 4 non-allocated RTs are actually making up for that 15% of the unpredictable procedures that can happen throughout the shift. And then, so the next thing is you got to get to start to work, understand what's going on at your bedside. So get a list of your procedures. And here's an example of, this list actually went up for a few, but I was able to get a list of all of our procedures, are the time standard from the SESG. And I asked for reports of how many procedures did we perform that year. And then when I got that, I had the number of minutes performing each of those procedures, which gave us down here about 109 million minutes of work done. This was the year prior to me coming. So I'm going in blindly and saying, by last year, if you divide that by 60, that gives you hours. You divide that by 2080, which will give you the number of FTEs. I said, from last year, we did around 88 FTEs of clinical hands-on work. But again, that's assuming they were running around like genies. In order to do that, and if you assume that 80 to 85% productivity, you actually needed about 110 FTEs total. Remember, I was budgeted for about 89. And they said, that's wonderful. We'll give you 91. And so I didn't quite get the 110. I said, that's something, that's great. I'm gonna watch it for the next year. So what did I do? I kept collecting this data. And the next year I said, hey, same thing. The number of minutes we performed this year was 12 million. If I do the math, we actually needed 98 we did 98 FTEs of clinical work. If I assume 85% productivity, I actually needed 115 FTEs this year. And, and that was eye-opening to them because they said, well, you predicted 110. I said, exactly. So, of course, this was a triple-demic year. So, yes, I was a little bit off. But I said, if we trusted the methodology, and it actually worked out that the difference between what I was budgeted for and what this predicted was exactly the number of FTEs I spent in bonuses and travelers. I said, if we increase our budget, I can replace all of those with full-time FTEs and have a cost savings. And they said, yes, that's great. you get 2 more FTEs for next year. And I said, great. So then I started again. And in the middle of the next year, I said, I told you I needed 115. I'm going to stop halfway through. And on average, doing the same methodology, we'd already used about 113. And this was now 2.5 years of data showing that if we had switched the SESG methodology, I could reliably predict and budget accurately for how many FTEs we actually needed. So after a lot of, I say I am annoying, but I like to say joyously. I'm joyously persistent. I continued having these conversations. It did not happen overnight, but after 2.5 years of just telling the story, having them understand, and showing data that actually spoke for itself, we effectively changed the budgeting philosophy here at CHOC, and our unit of service is now validated time standards. We now build in 15% non-allocated time. So those 4 non-allocated RTs are budgeted into every shift. And the big thing was what I found when they were looking at our paid FTEs, they were including my 8.5 FTEs of educators, quality specialists, and managers. And that was that was hurting our productivity. So now we removed that because they understand they're not going out there with patient assignments. And I finally got approved for the FTEs that I've advocated for. And this is our new productivity report. Imagine that sea of red. It is now, I'm no longer on that red line trying to explain what's happening. It's accurate. It shows what we're working for. And it shows that we were actually short RTs. And this has greatly improved and opened up as we begin to recruit. So the biggest thing is just remembering the time standard, whatever we use is the benchmark. It is the only validated evidence-based benchmark to measure productivity. And when your C-suite says we need to benchmark productivity, they're really saying we need to right-size the FTE for our patients. And the SESG is the only way to do that. So in short, engage your executive team, whoever is making those decisions early and often. And data. It's the only common language we all speak. And of course, a little bit of sparkle. They need to understand our story. You are teaching them something absolutely new, but this is an effective way to effectively make change in your institution. And now I'm going to go over to Corey. So if you are successful with this, and now you've effectively changed your budgeting system to be based off time standards and RVUs, he's going to share what he did in his institution.
Hello, everyone. I'm Corey. Emily's done a terrific job in explaining all of the details there. And all I'm going to do is just, I don't want to duplicate what she has done, but I just want to show our process and what we had here. If you advance, and I'll have Emily advance the slides for me as we move along here. If you mind advancing, Emily. A little bit of background, quick background. I'm from Intermountain Healthcare. If you see the yellow and the gold, or the gold and the brown there, that is the original legacy Intermountain Healthcare. 2 years ago, we merged, and within that, all the areas within green is what we merged to. So we had 23 original hospitals, and now we added another 8. So we were up to 33. And with that merger, if you can advance next to there, we were learning that we were going to have one EMR system. So within 9 months of that announcement, they said we are currently on Cerner. We are now going to go to Epic. The team in green there in the Colorado, Montana area, they were already on Epic. So with that, you can imagine the differences we had already in productivity and billing across these two regions, and just the practices in general, if you can advance. So what you can click through those 3 things there. So what we found is that, one, this is how we had to kind of take a step back and say, okay, within Legacy SCL, those are the people, the company from Montana and Colorado and so forth, Sisters of Charity of Leavenworth. They had procedures and point systems. That's how they were identifying their workload and their productivity, but they were only allowed to use anything that had a CPT charge code there. So very limited in what they could get productivity for. Within the Legacy Intermountain, we had an RVU value, and we were able to have charge code, which were CPT, and then there were non-CPT related items there. So we had a little bit broader base, which was helping us, because within the Legacy system there and the teams over there, they're great RTs that are just working hard to the bone and couldn't expand and do the things that we were doing within the Legacy Intermountain there. So what was our future state going to be? Are we going to go to RVUs? Are we going to go to points and so forth? We had no idea, and there had been a lot of controversy and talk about what we were doing. You hear through the grapevine where we're going to, this is a great time to restructure everything in respiratory and how we're going to bill and so forth. You can advance to the next slide, Emily. So I want to identify our flow of process is kind of how we did it. We were going through Epic build. They said, okay, we're going to go start with the building of Epic, meeting with the respiratory team. We started going through the things that we had similar, what was already being used. And then we were getting told throughout this whole presentation and everything we were doing is that you're not going to get credit for this, and you're not going to get credit for that. We're staying with what we currently have in the former SCL network system there. No discussion to us as the respiratory therapists over in the Canyons region over here in Utah and what have you. And so that really threw us off course because we didn't know what we were going up against. So first of all, what we did is we identified some key stakeholders to help us and move this process forward. Obviously, we had to meet with finance and get some questions. Our CDM team, which is a charge description master team, we included medical directors and our nursing leadership. What we had to do is we talked to the finance or the medical directors and nursing leadership, let them know what we were doing, what was happening to us, trying to get their take on it, what was going on. We collaborated with them, was able to get data collection and analysis on the things that we were already doing, working together across the system, how we were adding value to what we were doing, because we had heard that they were going to eliminate a lot of things. So then we sought their feedback. We made adjustments appropriately to kind of get things prepared. If you go to the next slide, the first thing we did, you can click on that again, is we quickly threw out a standard or an SBAR, sent that to finance immediately because we didn't know what was going to go on. And with that, we presented our recommendation was to have the SCSG guidelines there available for us because they weren't sure what they were going to do, points or what have you. We proposed that to them and then gave them a few weeks, and we set up a meeting to discuss with them. You can click again there, Emily. And I think within that window there, I can only say that the ARC SCSG guidelines were our Bible. It's incredible. Without that information, that would not have made us as credible and pushed us forward as much as we needed to. Beyond that, we also collected other data metrics. You got your typical billing. We had historical data of what we were doing and how our views were how we've had our views, how we were staying within productivity and so forth as we moved along. And then before we went to meet with them, we connected with our business objectives. What we really did is looked at as a service line what we contributed to our enterprise's goals and strategy. We have pulmonary disease navigators out there and what we're doing with that. We have research studies that we're involved with. We work with the critical care physicians and leadership and nursing leadership in the SAT, SBT programs and so forth, and everything that we were doing and how we were adding value to things. And if we were to lose RTs and not get the productivity, then some of those services that we were providing would possibly not be able to be there for them to use. So you can go to the next slide. So what we did is we took a step back and said, before we went to the meeting with them to kind of propose what we had done, is we looked at our RVUs, current RVUs. Now this is I started in 92, way back then, and these RVUs were probably before me. And this is back in the time when you go and you do the chart, you got a paper chart, and you got to find things. And these were some old RVU values that we had. And as we moved along throughout the years, we obviously would just add RVUs. Our new procedure project, we would add the RVUs accordingly and move forward though. If you click one more time there. So what we did is that we took what the ARC had there, and we went line by line and all the things that we were doing and saw, okay, what matches this across? What matches these? And so we identified them and structured them all out and had that presented in a Excel sheet to the finance team as well too. Now, what we found as we were doing this, this is just a snapshot of some of them. Our RVU values through the ARC, the time standards were probably obviously more accurate than what we had. We had decreased our RVU values over time. If you advance to the next one. Sorry to keep you on your toes, Emily. One more time, you can click in our presentation. So what we did with all that data is we tailored it to the audience. This is all the finance team involved in this. Obviously, they're data driven. So we had a lot of graphs, a lot of visual things in there to show them what we could do, what has been done, and the new process involved there. And then obviously, we created or emphasized the quality and safety and showed them how much we contributed to good patient care, reducing admissions, length of stay, and so forth like that. And you click again. So what we did is also during the presentation is we went through all of the RVUs and said, okay, this is what we currently have. If we have the new RVU value system as we would like, this is the difference. This is where we're going to see the difference across the enterprise is we're going to see substantial drops in our RVU values because they've either decreased or what have you. And you click one more time. We also showed that where we would see increases in those RVU values across time. You can go ahead and advance to the next slide. What we also did is we took a quick snapshot in time. We grabbed 5 of the facilities out of the Canyons Utah region there and said on one day, on one shift, one person on those shifts, we said, okay, currently this is how we were looking at our RVUs. If we were to employ the new RVU values, the dedicated ARC values there, time standards, this is what it would look like. And this would be the potential difference. We wanted to show them that, hey, we are willing to change because there's a lot of skeptical finance team members that didn't believe in our RVU value system very well, thought that we were padding the system and so forth like that. But this really kind of helped them and show, hey, if you click one more time, Emily, it'll show that about 20% of the overall difference in RVU values across the enterprise was 20%. So as they looked at their numbers and they looked within their financial analysis in a program called Strata, they would see a difference in those RVU values, and they were more accurate, more timely, and so forth like that. So if you advance to the next one, implementation. So when it came to implementation, well, finally, I'll take a step back. So over weeks and months, the deliberation of everything going on, and they'd email me back, and I'd send them back information and so forth. And they decided that, yes, we will trust in what you're providing us and doing. They were already familiar with the RVU values and what we were doing. They felt great about these time standards. And where it really hit place too is the benchmarking that we could do across the system and across the country with other facilities that were doing that. Now, once we got the okay to do that, we were able to separate the productivity from the billing, because always our RVUs were attached to a billing code. Now we were within Epic, we're going to be able to produce or separate those two things. And once we got it going, well, we knew we had a system, but are we going to be able to capture everything in September here? So we actually performed verification of our RVUs. It sounds like we're going to be able to capture them all. It looks like it is. And then we provided communication to the managers and the bedside givers and showed them exactly what the changes will be, how will it affect them, and so forth. Now, within the Utah region area and Idaho, we were used to that. Where Colorado, Montana, and so forth, it would benefit them because they were really not afforded the opportunity to get credit for everything that they were doing over there. So even though it didn't change us very well, it changed our whole system, and the whole system was going to benefit and our patients, obviously. And click one more time there, Emily. So within the Epic build, what they did is, and I don't know much about Epic, but we're learning. And so he was able to just mark out those RVUs specifically so they could just click on them and show them when they were done there as well too. Now, that was kind of our overall process in doing that. If you click one more time there, we'll get into what we finally ended up doing. You can see that we were able to use charge codes with CPTs, non-CPT valued use charge codes, and then RVU general. So we were able to use all of those, every tool that we had at our disposal. And it wasn't easy. I'm going to be very honest. It was very interesting. I think the biggest pushback, or where we found our struggles, was our charge description master team, the people that identify the billing and so forth for you, because with all the transition and reorganization, we were up against a new group of individuals, team members, that were very unfamiliar with what we had done over the history of time. And so we fought for those procedures that we had historically done. You know, we weren't going to get charges for end-tidal CO2. We weren't going to get credit for DME, home oxygen setups, equipment setups, all the teachings and so forth like that. So it was almost losing our job, but we pushed back enough to advance it. And obviously with our medical director and leaders over the critical care, leaders over telecritical care, where respiratory is thriving in there, they pushed as well too, and said, we need to pursue this. So that was kind of our big story in a nutshell. We'll see when it goes live in September. We're just starting out now. We got a baseline, so now we're always going to have to tweak it a little bit and understand what we're up against there. Now, if you slip to the next slide there, Emily. One thing that we did, we're currently in the Cerner system, and we had no way of identifying where we were as a team and productivity and so forth like that. So within the Intermountain healthcare team, we came up with a staffing board that's used. And in this staffing board, it's able to track the RVUs at the beginning of the shift. It goes by order. So every order that's placed in Cerner and will be placed in Epic will have that RVU value assigned to it, and it will show up on this board. So at the beginning of the shift, we can identify what our total RVUs are going to be. We'll be able to identify how many estimated RTs we'll need on that particular shift, and then it'll go by shift current, previous, and so forth. But we also put in, you have, like Emily had stated, there's some RTs that are kind of outside the typical bedside roles. We have a pulmonary disease navigator. We have a DME equipment person that sets up everything and so forth. And you got your lead RTs and so forth. So in essence, they'd have 15 plus approximately 3 other individuals total on that shift. We were able to break it down by unit. We were able to show how many devices were involved, or procedures are included on each floor. We can look at it enterprise-wide now, and we can also break it down to the unit. And so you can see on some of those numbers there, if you go to the aerosol column there and you look down to right there, there's 210 RVUs that are completed out of the potential 570 for that shift. So it's real time. Once it's charted and documented, it drops that RVU value for us, and that has helped us, just because we had no other way. You obviously are using Excel spreadsheets at the end of the day and so forth, but you need that real time, because we have smaller communities, hospitals, that have to fluctuate their staffing. We call off individuals, or we know when to call them in and so forth. So if you click 2 more times there, Emily, within this slide, it will show us, we can look on the next shift, and we can look at the previous shift and what we had done. And so this was giving us a pretty good start and an accurate ideal of where we were. Last slide, if you click to that one, the next step in our evolution is that we're going to be able to have the total productivity at the end of the shift. But also the next one beside that will be our productivity for that shift. We will be able to see all of this in real time. And that was we're going to be using that within Epic as well too, because once it's, we only went by ordered items. Now you have the PRN items and so forth like that we didn't count for RVUs, because you just don't know when those things are going to happen, spontaneous parameters and the like and so forth. But what this is going to do, this new one here, is that every time that it's documented, it will then throw that RVU in, into the total productivity for that shift, running total for us. And then what we'll do is we'll be able to have an actual percentage, like Emily had stated, 85% or whatever the goal was, like that too. So just wanted to share that as well too with you, the advancement of things and what we're trying to do, and hopefully to share that with others as we move through this process. And I can't emphasize enough the incredible help that the AARC has been, other team members across the country, to help us push this through, and to do so. And I'm here to help in any way the next individual or a group of members that want to do it. So that's all that I have at this time.
Thank you, Corey. I think I'm first in line to ask you for help. He showed me some of the work and I was so excited. And, you know, I talk about how challenging it was to make that change and make that case in one institution. And I can't imagine. So now you, like what you described at the beginning, you are also now, however many other institutions also convincing their senior leadership, those finance teams. So this is incredible work. So I was very excited to hear what you were doing.
Yeah, this is incredible. I want to thank both of you for sharing your journey and how you've really used the tool that has been given to us by the AARC, and really finding ways in which we can utilize it. So